From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at the performance of an automated machine learning for predicting diabetic retinopathy progression from ultra-widefield retina images. And joining me are Dr. Paolo Silva and Dr. Jennifer Sun. Dr. Silva is an associate professor with the Department of Ophthalmology at Harvard Medical School in Boston. Paolo, thank you for joining us.
Thank you, Neil, for the invitation, and thank you to JAMA Ophthalmology.
And also joining us, Dr. Sun. Dr. Sun not only is on the editorial board of JAMA Ophthalmology, but is also an associate professor with the Department of Ophthalmology at Harvard Medical School in Boston. Jenny, thank you so much.
Oh, thank you, Neil. It's always a pleasure to join these podcasts.
Great. And maybe, Paolo, I'll start with you. And my question would be, what was the impetus for wanting to develop an automated machine learning that might predict diabetic retinopathy progression from ultra-widefield retinal images? Has this been done before? Was this new? What made your group want to explore this?
So this approach hasn't been done before for predicting progression, and also with the use of ultra-widefield images. I think one of the most important and most difficult questions clinicians have when they evaluate patients with diabetic eye disease is predicting who gets worse, which eye will get worse in 3 years. So those are important questions that clinicians ask each time they see a patient. And these involve not just clinical decision-making, but really how long the follow-up should be, how soon should the patient be seen, and should we treat these patients? I think being able to use AI to be able to predict who gets worse and identify eyes at higher risk is critically important.
And Jenny, how good are we at doing this just by looking in the eye? Approximately how well do ophthalmologists do in general? Do retina specialists do any better than that?
Well, we know that we have some classification systems for diabetic retinopathy from the early treatment diabetic retinopathy study that are widely used, but can in practice be difficult to implement clinically. These systems have many levels to them. There are many different lesions that we look at. It requires really an understanding of what the standard thresholds of comparison are from the ETDRS standard photos. And that's hard for a busy clinician in the midst of their busy day to be thinking about all the time. So I think although we can certainly do it, and there are many retina specialists who are excellent at the clinical exam and good at knowing which of their patients are at higher risk of progression in the near future, I will say I think the ability to document diabetic retinopathy on photos and be able to have this kind of automated screening and triage is really important as we think about global communities and large populations.
Very important. Paolo, maybe you could tell me, you mentioned that this was not done previously with ultra-widefield images to our knowledge. How well was it done with just other retinal images? Perhaps it was 30-degree photographs that were taken in various fields. How good were those so far, and are any of those commercially available to guide us?
Right, so there's no commercially available algorithm that's available to clinicians for this type of prediction, but there are prior studies that looked at clinical trials data, specifically from the RIDE and RISE data, and they looked at which fields, which areas of the retina are predictive of progression. And some of the findings and observations of those prior authors was that the peripheral fields 1 to 7, and potentially outside of those fields, may provide greater prognostic value than when you look at just fields 1 and 2.
And Jenny, maybe you could give our audience an idea of where these ultra-widefield images came from. I know you used, as is typically done now in these automated machine learning evaluations, you used about 80% of them for training, maybe 10% for testing, and then 10% to actually test or validate what the machine learned. But how many images did you use, and where did they come from? Were these from one practice? Were these from across the country, across the world? Where were they from?
So this was a set of nearly 1,200 images from 700 patients with diabetes. All of our images were taken from clinical practice in the Beetham Eye Institute of the Joslin Diabetes Center, where Dr. Silva and I both practice. And the images were taken from 2016 to 2022 throughout that time period. I will say, I think we at Joslin have become more and more reliant on ultra-wide field images because of the ability to capture such a large percentage of the retina, usually about 80% of the retina in a single image, very quickly in a quarter of a second. And it's much easier to do this and much more tolerable for our patients than the 7 standard fields that we've relied on in the past. And so I think we're seeing also more practices, just like Joslin, using ultra-wide field images across the country, across the world, which also makes this kind of work, I think, very relevant.
I would agree. I think if these other systems that tested on, let's say, 30-degree photographs become commercially available, but everyone's taking a picture on ultra-wide field, we probably need this as well. So, Paolo, how many of these eyes actually progressed? So you knew the answer to train the machine. So of these 1,200 or so participants, or I'm not sure if it was participants or eyes, how many of them actually progressed over the 3 years?
Yeah, so when we create these training sets, it's very important that these are well curated. So these images had paired baseline and follow-up images, and both baseline and follow-up were compared to ensure that there was indeed progression. And when we developed the training data set, we had 50% non-progressors and 50% progressors. So a good split between the two. That's essential when you create these data sets. And we had another data set called our validation set. So this tested out the performance of these algorithms that we developed using a set of image that the algorithm has never seen during training, optimization, or testing. So in this testing validation set, we tailored the severity levels as well as the progression rates to what you would see clinically. So instead of seeing at 50%, so for the eyes with moderate, the progression rate was around 20%. And for the eyes with mild, this was much lower at around 10%, which would mimic what you would see in clinical practice.
So, Jenny, how well did the machine learning do once you trained it? How close was it to the actual progression, this 10% with the mild non-proliferative cases, this 20% with the moderate non-proliferative cases? How well did it do?
These models actually did pretty well. And I think one of the things, and maybe Paolo, will comment on this later, is the fact that he really built these models using automated tools without code, so that, these are algorithms that are available on the web to people who don't necessarily have specific AI development expertise. And yet, using these sort of out-of-the-box tools, in the validation set that we had, more than 3/4, about 78% of the eyes with mild non-proliferative retinopathy at baseline and 85% of the eyes with moderate NPDR that progressed were identified by these algorithms. The other thing that we saw was that when we look at just eyes with fairly rapid progression, so eyes with mild NPDR that progressed within the first 6 months or the first year by 2 or more steps on the ETDRS scale, we were able to identify 100% of those eyes. And we were able to identify 85 to 90% of the eyes with moderate NPDR that had quick progression within 6 months to 1 year.
So, Paolo, I get it. This worked pretty well because most of the people, 10%, as you said, with mild non-proliferative and 20% with moderate non-proliferative, most of those people that progressed, the machine picked it up. How about when people didn't progress? Did the machine say, oh, you've progressed, when they really had not progressed? How did it do with trying to avoid false positives?
Yeah, so we look at this in terms of sensitivity and specificity. So for the model looking at mild NPDR, the sensitivity was 0.72 and the specificity was 0.63. So this was a little bit lower in predicting, but you have to look at this from a screening perspective. When you're looking at it from a screening perspective, you want to potentially pick up all eyes that progress. This would ensure patient safety, to ensure none of the eyes that are at higher risk for worsening are missed.
So you might have a few extra that come in that the machine said, there's progression, and then you look in and you say, I don't see it. Did you look back at any of those? And were they perhaps graded improperly by the official curation that you did, or you haven't had a
Yes.
chance to look at those?
We did. So we agreed with most of the grades, well, almost all the grades, because these were all triple curated, meaning they were graded by graders, and I also validated those grades. So I think the robustness of the data is really because the data of the image grading was so good. We ensured that that was really the grade that was present in the eyes.
So, Jenny, this is a great first step. Do you think more training would end up even better? As Paolo said, the specificity was good, not great. Do you think you can get this to an even better level with more training? Do you have plans to do that?
So I certainly have high hopes that additional training, additional work with these models can continue to refine them. I don't think we've reached the limit of the technology at this point. And I think one thing that is very important is the acknowledgement that initial training on a specific data set needs to be looked at to understand the limitations of that data set, and in particular, the diversity of the patient population that you're using. And Paolo's done some beautiful work on this, showing that images that are trained on a predominantly white population may behave very differently when you take them into populations of Black or Asian or, other underrepresented minority groups. And so it's really important, particularly as you think about where you're going to be deploying these algorithms, to make sure that you understand their performance in the groups of people that you're using.
And Paolo, my last question is, we've seen so much great science come out over the last few years about using artificial intelligence and automated machine learning for retinal images, but they're not typically part of our practice at this time. Do you think this science will then be taken and given to us in some applicable way in the future? What's your expectation for where this science then gets applied in clinical practice?
So I think the benefit of AI is multifold. I think it improves our knowledge, our understanding of eye disease, especially for changes that we don't see readily. I think for these sets, we've looked at heat maps, and some of the images are shown on the publication, some of the heat maps that the AI identified. And those images highlight areas that we traditionally have not looked at more readily or easily. And these could be avenues for future research. Also, expanding AI with larger data sets, more collaborative efforts, more diverse populations is really key. And with any AI algorithm, patient safety, standardizations is always important. We need to look at diversity and also looking at prospective validation of these studies.
Well, we look forward to your team and others around the world for sharing and providing that to us. And I want to thank both of you for joining us today. Thank you, Dr. Silva.
Thank you, Neil.
And thank you, Dr. Sun, as well, for all of your work in this field.
Oh, thank you so much, Neil.
We've been listening to Dr. Paolo Silva and Dr. Jennifer Sun from the Department of Ophthalmology at Harvard Medical School in Boston, discussing the performance of automated machine learning for predicting diabetic retinopathy progression from ultra-widefield retinal images. I'm Neil Bressler, and thank you for joining us. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.